Assalamu alaikum. Can you hear me? Anybody?
Hi,
Assalamu alaikum, Dr. Huma. Can you hear me?
Yes, I can hear you and I can see you.
Yeah, great. Good to see you. So
how are you?
अभी है 10 मिनट. I'm very good. अभी 10 मिनट है मेरे ख्याल में. हम just.
अस्सलाम वालेकुम डॉक्टर हुमा, कैसी हैं आप? डॉक्टर काशिफ हेयर, कैसी हैं आप? ठीक हैं?
बिल्कुल ठीक ठाक, अल्लाह का शुक्र. आप सुनाओ कैसे?
मैं बिल्कुल ठीक हूँ. कराची में है इस वक्त? इस्लामाबाद?
बिल्कुल कराची में है. नहीं, इस्लामाबाद तो छोड़ दिया.
मैंने छोड़ दिया था ना, फिर आपने, मैंने कहा शायद फिर कोई बुलाया हो आपको गवर्नमेंट वालों ने. आप तो उनकी बड़ी हेल्प कर रही हैं.
इस्लामाबाद की खबरें तो हमें पता लग जाती हैं.
इस्लामाबाद आप अपने हरकारे भेजते हो ना, इसलिए खबर पड़ जाती है आपको. असद
थका दिया इन्होंने. अभी तो बेड पे आ गए हैं, मान से फ्राइडे से लगे हुए हैं.
तो कौन सा भाग रहे हो यार, जगह बैठे ही तो हो ना. उस पे भी ये हाल है.
मैडम आपको क्या बताएं, इतना आसान था. मैं कहता हूँ वर्चुअल ने तो हमें किया. एक चेयर पे सोफे पे बैठ के ना, समझ कुछ नहीं आ रही. सिर्फ जुमा पढ़ने निकला घर से, मैंने सूरज नहीं देखा. उसके अलावा इन्होंने कमरे से
पहले तो भाग जाते थे ना, बस अटेंडेंस लगाई और भाग गए. अब बैठना पड़ रहा है तो मुसीबत आ रही है.
जी जी. मुसीबत क्या है मैडम, मतलब इतने आते पड़ गई ना. नए लोगों को लगाएं इस पे. हम तो फिर कम से कम घूम फिर लेते थे, कोई चाय पी लेते थे.
सही बात है.
आरिफ साहब बैठे में. आरिफ साहब अस्सलाम वालेकुम. आप खोल लें जरा आवाज.
जो सबको आवाज नहीं आ रही हमारी यार, सुन नहीं रहे आप फिर.
नहीं बिल्कुल
आपने खोल दिया, आपका म्यूट हुआ.
अच्छा, तो भी मीटिंग हमें 10 मिनट पहले शुरू कर दी आपकी. अब इतनी दहशत होगी सुबह. मैं और जीशान तो हम डर के बैठे हुए हैं यहाँ पे, क्योंकि ये जो फारूकी साहब वाला रूट है ना, ये ठीक नहीं है. वैसे ये फारूकी साहब वाला रूट ठीक नहीं है. तो ऐसा पड़े गए हो, सीक्रेट आउट हो गया
ना. मैडम जी कैसी हैं?
अल्लाह का शुक्र है. आप कैसे हो जावेद? अल्लाह का शुक्र, बिल्कुल
ठीक ठाक. बड़ा जिक्र हो रहा होता है. अभी 10 साल पूरे हो गए. वी नीड अनदर सर्वे जी. उसके 10 साल गुजर गए. नए बताएं ताकि हम प्लान करें हाउ टू एलिमिनेट HCV फ्रॉम पाकिस्तान. वी नीड अनदर सर्वे जी, डेफिनेटली.
जावेद, नए सर्वे तो हो गए ना. सिंध का भी हो गया, पंजाब का भी हो गया.
जो आपने किया तो हो गया.
मेरी बात सुने. मैं टॉक्स खत्म होगी तो डॉक्टर हुमा को पूरा टाइम दे रहा हूँ. आपने उनको टॉक ना दे के ना जाती की. मेरी क्लास होगी पाकिस्तान में, ठीक है, तो इसलिए मैं पूरा टाइम दे रहा हूँ. तो मुझे कोई कुछ ना कहे, ये मेरे हाथ में है, ठीक है.
देखिए, कल भी रात को जो ग्राम फोस्टर बोल रहा था मैडम की सर्वे पे, रिजल्ट्स पे, उसको जो है ना, दैट वाज वन ऑफ द स्टडी की जिसपे WHO भी जो है ना, वो एलिमिनेशन पे बात आ रहा था कि किस तरह करना है पाकिस्तान के लिए भी. और आई थिंक उसकी ये जो सर्वे था, दैट इज द माइलस्टोन ऑफ हेपेटोलॉजी नेट इन पाकिस्तान इन दिस रीजन. मैडम ऐसे, आई मीन दैट वाज समथिंग कि आपने जैसे किया उसको, वी नो दैट कि जिस तरीके से आप गई और जिस तरीके से यू ट्रैवल टू द फार एरियाज. बट आई थिंक नो, वी नीड वन फॉलो अप, स्पेशली उन जगहों पे कि जहाँ पे उनका प्रिवेलेंस बहुत ज्यादा था कि आया हमारा कुछ इम्पैक्ट हुआ है, नहीं हुआ है. क्लेम तो सारे कर रहे हैं कि जी हमने कर लिया है, लेकिन
जावेद इसी का मैं बता रही हूँ कि पंजाब ने 2018 में सर्वे किया ऑल ओवर पंजाब, और सिंध का मैंने अभी सर्वे 2019 में किया है. एंड आई एम श्योर आपको इन दोनों सर्वे के रिजल्ट्स पता चले होंगे, क्योंकि मेथडोलॉजी वही थी. तो आपने देखा कि पंजाब में जो है वो 6% से 8.9% चला गया है, which is very very high.
Let me welcome Professor Sanjeev. Sanjeev, we welcome you. Thank you very much for joining. So I hope you are understanding what Dr. Huma is saying in Urdu.
Sanjeev understands Urdu very well. I know. I met him in Delhi.
you know, I'll be interested in the KP results. In initial maybe the KP was probably not properly covered. The reason was the unrest, political unrest and geological unrest across the different areas.
नहीं, आप सही कह रहे हैं डॉक्टर जावेद. बात यह है कि KP और बलूचिस्तान में अभी नहीं हुआ है recent survey. There's no survey for Balochistan and KP, and even for Gilgit-Baltistan and for AJK. So now we have requested, the CDC USA to kind of, because they have some money and they said they could support it. तो हमने उनसे रिक्वेस्ट किया है कि इन 2 प्रोविंसेस और इन 2 रीजन्स में भी सर्वे कराएं ताकि हमें वंस एंड फॉर ऑल, मतलब इन 2 प्रोविंसेस का तो फॉलोअप मिल गया है, बट इन 4 जगहों पे 2 में फॉलोअप मिलेगा, 2 का फर्स्ट टाइम होएगा. So we are at it, inshallah, very soon in दोनों provinces का भी होगा सर्वे.
Yeah, that's very important. The reason के केपी का बहुत सा बंदा पंजाब में है, कराची में है, and this is a risk कि अगर हम यहाँ से नहीं करेंगे, sorts of risk है, वहाँ पे भी जो है ना elimination will be really a problem because most of our people they are working in Lahore, Punjab, Pindi, कराची तो भरा हुआ है पठान से पूरा. मेरा ख्याल में कि स्पेशली उन एरिया से कि जो कवर नहीं हुए थे उस सर्वे में, मालाकंड, दीर वगैरह, या फिर वो स्पेशली अपने जो ट्राइबल एरियाज था अभी तो वो सेटल्ड हो गए. तो आई थिंक वी डेफिनेटली बिल्कुल दैट विल बी अ ग्रेट समथिंग.
दीर तो जावेद, अगर इफ यू रिकॉल तो दीर वाज डन एंड अपर दीर, लोअर दीर तो मैंने खुद जाके किया था, एंड इट स्टिल स्टैंड्स आउट एज अ हाई प्रेवलेंस एरिया इन केपी. So yeah, but I agree कि जी होना चाहिए. सिर्फ बात यह है कि actually provinces have to request. Unfortunately, KP province और बलूचिस्तान province ने ना WHO को ना CDC को request नहीं की है, तो without a request कोई भी funder कुछ नहीं देता. So I think what I would request you कि आप वहाँ पे जरा किसी को कहें.
Dr. Wahid Dos is there.
Yeah, very good.
Hi, Dr. Wahid. How are you?
Dr. Wahid, you are with us. So I think we now switch to English
we can
only.
Start.
Asad, I just wanted to check. Can you hear me?
Yeah, we can hear you, Sanjeev.
Okay. Thank you, Huma. I fondly remember meeting you in Lucknow.
Yes, I remember that. It was a very short meeting of, but yeah, we did discuss quite a few things even in that small span of time. Yeah. So how are you enjoying the eco?
Good. It is now spreading it has become significantly different and bigger than it was when I met you in Lucknow. So hopefully I'll get a chance to share with you today.
Oh yeah, hopefully, yeah, we will be happy to see. And in fact, Asad and Zishan are your babies because they're kind of propagating your baby further in Pakistan. And we're very happy with them because they do a very good work. They're connecting people and they're helping in training and healthcare people in the far-flung area. So they're doing a very good job for us. Thank you.
Thank you. Thank you.
Dr. Wahid Dos, are you with us?
Hi. Good to see you again. Really?
Oh, good to see you again.
Hi, Wahid. How are you?
How are you, ma'am?
I'm
it's
fine.
Good to see you again, all of you.
Good to see you again.
Even,
that's what I thought that. Yeah,
are you okay?
Yeah, I'm fine. Yeah, I'm fine. Thank you.
And I always cherish the few days I spent in Lahore with you in your last Congress. Very dear to me. I had a lovely time with you 2 years ago, really. And I hope we can do it again. And I hope you can come to Cairo soon.
Yeah. I hope this COVID goes away. Then we'll all be traveling because this is the first time we are all, far away, talking to each other on computers. But hopefully COVID will clear off, and then we will be back in Egypt and see you soon.
Absolutely.
So I also welcome Hashmi Saab, Jahiz Yasin Hashmi, who has loads of experience in treating hepatitis patients and spearheading, mentor, inspiration for all of us from Faisalabad. So welcome, Hashmi Saab. And
thank you, Joseph. Thank you very much.
Assalamualaikum, Zahid. How are you?
Very well, madam. आप कैसी हैं?
अल्लाह का शुक्र. बहुत साल बाद देखा आपको. Good to see you.
Thank you so much. Good to see.
Thank you.
Assalamu alaikum and good evening to everyone.
Thank you.
So should I start? I think we are right on time.
I think we can start because we have the faculty.
Yeah. Otherwise, we'll.
Yeah.
I can't see you. Yes. Wait a minute.
Bismillahirrahmanirrahim. My name is Dr. Asad Chaudhary, and I'm the co-host of this session. And I welcome all of you to this very important session on hepatitis C elimination and about ECHO. We are very lucky to have world-renowned faculty with us, and the aim is to know what the status of hepatitis elimination globally and where we stand in Pakistan, and different ways how to achieve this goal. We are working very hard in Pakistan, and I hope that in due course of time we'll get there. And I can now see Professor Graham Foster's name here. He wonderfully touched hepatitis C elimination last night, and we would like to hear from him his comments later in this program also. So I would like to start without wasting time. Our chairpersons for this session are Dr. Huma Qureshi. She doesn't need any introduction in Pakistan. She's a renowned gastroenterologist who has headed Pakistan Medical Research Council in past and still actively involved in federal hepatitis elimination program. She also represents the Health Foundation, of which a lot of us are attached, and she's one of the most active, and the Health Foundation is one of the most active NGO targeting hepatitis elimination in Pakistan. The other chairperson is Professor Yahid Yasin Hashmi, a hugely respected figure in the field of hepatology. He retired as principal of Punjab Medical College, Faisalabad, and now leads the Liver Foundation Trust in Faisalabad. Professor Mozumuddin Ahmed will be joining us. He is current president of Pakistan Society of Hepatology and has been key in raising the voice and impressing the national authorities on importance of hepatitis elimination on behalf of the organization. Dr. Sadiq Mehman is a dear friend from Asian Institute of Medical Sciences from Hyderabad, and one of those who have single-handedly treated the most number of hepatitis patients probably in that belt. So without wasting much of time, I'll go to our first speaker for today. And it gives me immense pleasure to introduce Professor Wahid Doss from Institute of Liver, Cairo, Egypt. He has been involved in over 70 research work, 1,000 citation, and about 7,000 reads on hepatitis C virus. He has played major role in building the hepatitis C model for Ministry of Health National Treatment Program in Egypt. So he will be talking about the Egyptian model of taking hepatitis C treatment to the people. So Professor Wahid Doss.
It's a pleasure to be with you again today and to share our experience in elimination of hepatitis C in Egypt. And hopefully Pakistan soon will be able to achieve the same thing we achieved in Egypt, which is right now we don't have any more hepatitis C patients who know of the diagnosis. And as I will tell you from my presentation, which is with you now, that we've been through a very long road, but eventually we have reached what we want to reach, which is to eliminate hepatitis C in Egypt. So shall I talk? Or I think that the pre-recorded lecture. Hello. Good afternoon, ladies and gentlemen. My name is Wahid Doss. I'm professor of medicine at Cairo University. It's my pleasure and honor to be with you today to share with you the meeting of the Pakistan Society of Hepatology. I had attended your previous meeting in 2018 in Lahore, and as I said, it's really an honor to be with you again. Today I'll talk to you about the Egyptian model of taking hepatitis C virus treatment to the people. Egypt had the highest prevalence of hepatitis C in the world. Egypt and Cameroon and Mongolia, to some extent Pakistan, we were the highest prevalence in the world. And this was the magnitude of the problem we had in Egypt in 2014. We had as many patients with hepatitis C virus in Egypt as there were in 38 countries combined in Europe, with a total population of 600 million. In sheer numbers, we were the fourth number of cases in the world after China, Pakistan, and India. And this is the sample we did for hepatitis C in Egypt. In 2008, the prevalence of hepatitis C in Egypt was 14.7%, of which 9.7% of our Egyptians had active viremia, which may mean that we had about 6,370,000 patients with active viremia. In 2015, another survey showed that there were about 7% of Egyptians had active viremia, a total of 5.5 million. Of course, we know that men are more exposed to hepatitis C than women, and that HCV viremia increases with age. So in the age group of 15 to 19, only about 2.8% of Egyptians are infected, and this goes up to about 30% in the age group of 55 to 59. So our national HCV treatment program was started in 2006 with the establishment of the NCCVH, the National Committee for Control of Viral Hepatitis. Of course, at that time, 2006, we only had interferon therapy. We started by establishing treatment centers all over Egypt, 26 centers, and we treated from 2006 to 2014 about 350,000 patients with interferon, pegylated interferon, and we had a cure rate or SVR rate of less than 50%, about 40%. So we had about 190,000 treatment failures. And of course, we all knew about then that interferon therapy was not the ideal treatment for hepatitis C. And we did a plan of action, prevention and treatment of hepatitis C from 2014 to 2018, which included educating healthcare workers, increasing public awareness, ensuring blood safety, safe injection practices, infection control, to treat over 300,000 patients annually, and to have support from the government for our HCV treatment program. In 2014, directly acting antivirals were introduced in the world, but we have limited resources in Egypt, so we started to negotiate the price. And we first had a price of $900 for 3 months, 12-week supply of sofosbuvir, simiprevir for $750 for a 12-week supply, dacatazvir, then lead Harvoni for $1,200. Eventually, in 2018, with the introduction of generic treatments in Egypt, we have a 12-week supply of sofosbuvir, dacatazvir of less than $40, which I think is the same price of generic companies in Pakistan. But do people always ask us, do generics work? We did study comparing brand sofosbuvir, dacatazvir, and brand sofosbuvir, ledipasvir with generics, and we have known that the generics and the brand work the same. And even if they have cirrhosis or no cirrhosis, and in naive patients or treated patients, we know for sure that generics work just exactly as brand patients, of course, with a fraction of the cost. You see, I'll go through the phases of HCV management in Egypt. In 2007, we started with interferon ribavirin, which is about 300,000 patients with an SVR of 40%. In October 2014, we started treating with the brand DAAs, and patient would have to apply to the treatment through the web-based registration system, where you put his name, his national ID number, and we gave him an appointment to come for the treatment. And in the first day, in September 2014, 100,000 patients applied, and every day we had applications, and patients would go to be evaluated. And then in January 2016, we introduced Egyptian generic DAAs. In 2016, about 2.5 million people were treated with an SVR rate of 96%. And who paid for the treatment? The government paid for the majority of the treatments, either directly or the National Insurance Organization. Some sponsors paid the treatment, and a few out-of-pocket patients. In total, we treated 2.4 million Egyptian patients from 2014 to 2018. And these are the combinations we used, mainly sofosbuvir, dacatazvir, sofosbuvir, dacatazvir, ribavirin. We did some people to receive simiprevir, Some people, he solved let it persevere, and we had a very high adherence rate, and treatment was fully funded either by the government or the National Insurance Organization. And this international coverage of our treatment in World Hepatitis Alliance, Unit Aid, Atlantic had the cover of the Egyptian treatment program. The New York Times on the first page was about the treatment of hepatitis C in Egypt, that a new approach could become a blueprint for providing cutting-edge medicines to the poor. And even the Lancet Gastroenterology had the full cover page on our Egyptian treatment program, and we had a lot of publications in also prestigious journals about our program. Even the famous footballer Messi came to Egypt to support Egyptian treatment program. But by 1918, we know that all the patients all the Egyptians who were aware of the treatment had been diagnosed and treated. And we know from our survey that we have about 2 to 3 million Egyptians who are unaware of the infection and who have undiagnosed hepatitis infection. So that's where we started a nationwide screening program in October 2018. Our target was to screen everybody over the age of 18, about 62 million Egyptians, and that's where the screening program started. And we also included in our program to evaluate hypertension, diabetes, and obesity, and to treat HCV if not previously treated. We used what we call a rapid diagnostic test, a finger prick test, which cost us less than $1, $0.6, and patients were antibody positive, had to do a viral load, which cost us less than $5. And this is our rapid diagnostic test. We had the test, it's very easy to perform, very easy to train people, and it costs us, as I mentioned, $0.6, less than $1, and the result will be available within 20 minutes. So immediately you can tell this patient if you have been exposed to hepatitis C or not, and if you are exposed, you have to do a PCR test. And this is our screening campaign. We started from July to September with planning, preparation, and procurement and training, and then we had 3 phases. Phase 1 with 9 states, phase 2 with 11, and phase 3 with 7 states. And then from May to July 30th, we had data evaluation. We had an external audit by the WHO, and we always had patient evaluation and treatment. So our phase 1 had 9 governorates, phase 2, 11, phase 3, 3. Each one started in a separate time, and we had fixed screening sites of 5,000 in phase 1, 6,000 sites in phase 2, and 7,000 sites in phase 3. And this is the map of Egypt with the 3 phases, and we had to train 18,000 teams over the country, and all data was entered through PCs or tablets in real time into central database via cellular networks. And this is a national screening campaign. We had to train 800 trainers to train the trainers, and this is we are planning to screen 62 million Egyptians. We actually screened about 50 million. We screened every day about 237,000. Every day we had 6,000 teams. Each team would screen about 40 patients, and we did about PCR labs would be about 1,000, and each one did 700 tests per day. And we had mobile units all over the country in mosques, churches, clubs, factories, subway stations, huge media campaign, billboards, TV, radio, and anybody just walk into any site would be tested immediately and linked to evaluation and treatment centers. So as I mentioned, we had about 32 million men in the screening program, 32 million population screened, and 30 million women. We had a seropositivity of about 4%. And this is our dashboard, depending on each phase, and depending on every governorate in Egypt, what was the target population, what was actually screened. And then we had these our results from in October 2018. The HCV seropositivity will increase with age. So at the age of 15 to 18 is about 0.4% and goes up to about 4.5% at the age group of over 65%. And about 2 million patients were treated after that. And this is our cascade of treatment for hepatitis C from October 2018 till August 2019. The total screened was about 49,800,000. Total positive was 4.4%. We linked to care about 1.5 million, about 72%, 1.1 million who had positive PCR, 1.03 started treatment, and by now I can tell you that by this time everybody who was diagnosed with hepatitis C had been treated. So everybody asks in Egypt, what about elimination of hepatitis C? So the WHO committed the goal of achieving HCV elimination by 2030, that we should have 90% reduction in new chronic infections and 65% reduction in mortality. So will this be achieved in Egypt? Yes. In 2013, we had cured only 3%, and we had diagnosed 20%, and only 10% linked to care. In 2018, the cure rate was up to 36%, while in 2020, it is up to 85%. So we still have ongoing screening efforts, people incarcerated in prisons, people with special needs. We have teams which go to their homes to be tested. Egyptians abroad, when they arrive in Egypt, are screened. We, of course, screen all blood bank donors. We have all inpatients of government hospitals are screened on admission. We even test refugees in Egypt, and we have an initiative to treat 1 million patients in Africa from hepatitis C. So school children, we have targeted 33.7 million, and we have screened 3 million, have a positive HCV antibody of about 0.37%, less than 1%. And preparatory school, our target was 5.4 million. We screened 3.9 million, and the positivity rate is 0.22%. Patients incarcerated, we have a higher percentage of positivity, about 12%, and refugees in Egypt, about 1% are infected with hepatitis C. So in conclusion, Egypt is currently on fast track to HCV elimination. From 2014 to 2018, we treated about 2.5 million Egyptians with mainly with soft DAC, daclazavir, with a cure rate of 95%. From October 2018, we screened about 49 million Egyptians. 2 million are being positive, and all have started treatment. We have a potential to be the first country to eliminate hepatitis C. So this has been the largest screening program in the history of medicine. From 2014, over 2.5 million treated, mainly with generics. From October 2018, we have treated about 2.3 million. So we have the potential to be the first country in the world to eliminate HCV despite high burden and limited resources. This example is easy to follow in similar resource settings. Conclusion, Egyptian National HCV program very successful despite limited resources. Factors contributing to success: social pressure for government funding, political will and support, setting up infrastructure for mass treatment, negotiating mass purchase prices, fully reimbursed or subsidized treatment for all, simplifying treatment decisions, and very important, low-cost generics. And these are the National Committee for Control of Viral Infections members, and I'd like to thank you all.
Thank you very much, Dr. Vaidos. Amazing figures and amazing job done in Egypt. I would like to introduce one of the chairpersons I actually missed. I apologize for that. Professor Dr. Abdul Qadir Khan, who's professor and head of Department of Medicine and Gastroenterology from Muhammad Medical College, Mirpur Khas. Welcome, Dr. Abdul Qadir Khan. Sorry for this miss. Our next speaker is going to be Dr. Gyasun Nabi Tayyab. He is professor of medicine and gastroenterology at the Lahore General Hospital. To his credit, is setting up one of the most advanced gastroenterology unit in Pakistan and introducing advanced endoscopy services. Professor Gyas has been instrumental in initiating the Punjab Hepatitis Control Program, benefiting millions of hepatitis patients. And who else can better speak on challenges of hepatitis C elimination in Pakistan? So, Professor Gyas, please.
Thank you, Dr. Asad, for giving me the kind of opportunity to speak on a very important topic of hepatitis elimination in Pakistan. We have just heard the brilliant talk by our brother, Professor Wahid, where they have achieved the elimination of hepatitis C in 2020, while our target is achieving hepatitis C elimination in Pakistan. I can clearly understand that in the audience we have Professor Huma Qureshi, and I know that she is a much better and eligible person to speak on this topic because she is the one who has been collaborating with me and all others in the elimination of Pakistan. I'm really thankful to Pakistan Society of Hepatology for inviting me here to talk on a subject which is so close to my heart because my mother died of hepatitis C. And Pakistan Society of Hepatology has given me the opportunity to interact with all the colleagues, although I understand that the conferences are meant to meet in person, chat and greet each other on these occasions, in addition to the sharing knowledge. But nevertheless, at least we have the privilege to sharing the knowledge on a very important subject like this. I don't have any financial disclosure to make relevant to this presentation, but I have been Project Director for Hepatitis Control Program or Specialist Healthcare in Punjab until 2019. I developed management guidelines 2020 on hepatitis C for Punjab Hepatitis Control Program, which are being used at the moment. And I've been member of the Committee for National Guideline Development on HCV Management under National Health Department in the past. And I'm a member of the Steering Committee for Development of Hepatitis C Program along with Dr. Huma Qureshi. And then I've been on numerous other chairs relevant to exactly the same thing. Now, what challenges do we have? We have heard an elegant talk by our worthy brother, Professor Wahid. Now, exactly in the same way, we have to make a decision that whether we need to treat now or we have to treat or we can treat the patients later. We have to find the missing millions which are there in the community. And let me tell you, all those people who knew that they are infected, they've got themselves treated one way or another, either from the public sources or from their own private sources. Now, we need to, as a healthcare deliverers, we need to decide how to come in contact with the people. Either the people are going to come to us and the established centers that we have, macro elimination, or we have to go to the community micro elimination, the kind of program that the Egypt has outrolled. And then the partnerships with all the other sister organizations, for example, the kind of partnership that Punjab Health Department has developed with Dr. Chaudhary in his NGO, and similarly at so many other places that we have to develop, like we have to develop the partnerships with the family physicians, the most important component in the health delivery system in Pakistan, and then the advocacy groups, the advocacy people that they need to come forward to tell the people that, look, we were suffering hepatitis C, we got ourselves treated, and the significant adverse effects that could have happened and they used to come across with the interferons, they're no more there. And finally, managing the impact of COVID-19 on hepatitis control that we have gone through in the past. You have seen this slide previously as well. And let me tell you that after the successful elimination of hepatitis C in Egypt, we stand out to one of the most viremic countries, rather the most viremic countries in the world, leading to the high morbidity and mortality rate to hepatitis C in terms of leading cause of death, and the ever increasing number of hepatocellular carcinoma in the community, which we have started to see every now and then. And finally, liver transplantation is considered to be the ultimate treatment for these patients. We know that although it is possible, but then that's a very, very expensive option. We have to do something. We have to work hard to achieve the hepatitis C virus elimination by 2030, and that is only possible if we make a proper plan. Egypt has achieved this thing: 90% reduction in the new patients, 65% reduction in the morbidity. But let me tell you that in Pakistan, the things are more complex. We have much bigger population. We have a much scattered population. We are a country bigger than Egypt. At the same time, the scatter is more different as compared to the Egypt. So the things are a little different as compared to Egypt, and our plan has to be more robust. And these are the 5 things which we need to target. Testing. By 2030, we expect that the 90% of population should have been tested. Let me tell you, in Punjab, we are on the right track. We have been working hard to achieve that. Sindh is not too far away. KPK and Balochistan, they're also working hard to achieve this. Treatment, we have been able to treat a good number of patients in the past couple of years. We have been able to treat more than 175,000 patients in our community. That's just in the public sector hospital. And then the people who could afford, they've got themselves treated in the private sector. The NGOs like ECO, like Server Foundation, like so many other organizations, they have played their part in the treatment of people. Harm reduction in terms of order disposable syringes or needle provision to the people who need injection for one reason or another, and prisoners, for them, we need to increase our surveillance better. And then as per the Safe Blood Transfusion Act, we need to improve our blood safety to 100% by 2030. And similarly, injection safety, we are again a country who love to take injections. And as a medical community, we love to give injections. We need to bring a change in this. People should stop expecting injections, and the doctors should stop giving injections in the name of therapy. But how good we have a testing facility. Not many years ago, 2014, we are testing in the lower side, less than 20%. And with the passage of time, we expect that we need to treat better. Now, the question is, do we need to treat now or later? A very elegant study by one of our own ex-students, Fasia Kawal, had been published in the Journal of American Medical Association. Lately, there have been two studies which have been published on the modeling in terms of possible elimination in Pakistan. One of them is this, and another one which I've avoided sharing because of the cost of time, because this is something which is more relevant to us. So just to share that HCV testing would need to scale up to at least 25 million people to diagnose 900,000, so that by 2030, we should be able to achieve 90%. And as soon as they get diagnosed, we need to treat them. So that is the first message, that we need to scale up our testing in order to achieve the cure, in order to achieve the treatment. And by this, by 2030, we expect that there's going to be a 99% reduction. And if we continue to do exactly the same, meaning by status quo, where there's been disorganized efforts, we will be able to achieve just 12% reduction in the total pool of the patients, because on one side, we'll be treating the patients, on the other side, there'll be more number of patients getting added to the already existing pool. And we need to treat 7.7 million people, so that we should be able to achieve the elimination goal of WHO, as compared to if we continue with the status quo of, as the figures project in 2015, by treating just 1.3 million. So from 1.3 to 7.7 million is the target, and 234% improvement, 90% improvement is required. Now, how about the awareness of infection? Right now, we don't have much awareness of infection. Even when we talk in the policy making committees, lots of people still come up with the idea, or still come up with the notion that hepatitis C spreads by the contaminated food and water. Although the number of people talking about this notion is not as low as it used to be in the past, but still, I shall say that only 1/5 of the people have the exact idea, and we need to increase it to at least 99%, meaning by everybody should know that hepatitis C and B is spread through the contaminated blood and none else but contaminated blood, and contamination of the infected blood needs to be stopped at every cost. Only then we'll be able to reduce this incidence of new cases from 281,000 in 2018 and 325,000 in 2020 to just 9,200, the target that we want to achieve by reducing 97%. And that's how we are going to improve the HCV-associated deaths, disability adjusted life years in the Pakistan with the conventional approach, or with the upscale testing. And then in elimination stereo, there's going to be 65% reduction in the HCV disease burden, although we all understand that even with the 45% people who are presenting at F3, F4 stage, even if we are able to control the hepatitis C, still the HCV-related death toll, HCV-related morbidity because of the ongoing chronic liver disease and complications is still going to be there, but not in the same magnitude as it is in the past. HCV-related deaths will be there, but to a much lesser level as compared to if we continue without having an organized effort without going through a very, very aggressive approach. And then decompensatory cirrhosis definitely is going to get reduced. At least 44% reduction is expected. Cumulative incidence of HCC is also expected to come down with an early treatment, effective treatment, and then continuous surveillance for these patients. And it's a matter of deciding whether we want to spend the money, spend the energies, and spend efforts now, or we want to continue spending the same effort. We want to continue lots and lots of money for rest of our life and rest of the years in Pakistan to control this disease. So in the elimination scenario, what we need to understand is that we need to spend the money early, especially in the first 3 years, from 2020 to 2023. They're the most crucial years. If we're able to scale up our effort in testing and then providing treatment, meaning by the linkage to care, any person who comes in contact with the healthcare system, he or she should be tested, because we fall in a zone where the incidence rate is more than 5%. So anybody who comes in contact with the healthcare system, we need to test it and test them. If they're found positive, immediate linkage to the care, irrespective of whether the person is pregnant or non-pregnant, young child or elderly person, young adult or a grown-up adult. All these cases need to be linked to the care by testing for their nucleic acid, meaning by HCV RNA. If found positive, to be provided them with a treatment there and then. 3 months treatment. Soft DECLA is very cheap, is readily available in almost all the health departments. So we just have to continue with that. And in exclusive community, we can talk of giving soft WELP as well. Now, what are the strategies to find the missing millions? I've already said that we need to build up the infrastructure. All the health departments after the devolution in 2000, each and every health department has been trying to develop the infrastructure. And I shall be talking exclusively about Punjab because I've been heavily involved in the Punjab. Although we can talk about Sindh, we can talk about KPK and Balochistan as well. But let me tell you that as regards infrastructure is concerned, in the past 8 to 10 years, Punjab has covered lots of grounds, and they've been able to provide the services through 147 clinics, which they have developed all across Punjab. In terms of strategies, I've already said that we have macro elimination strategies. In micro elimination, we have tested a strategy in Nankana district, and then we want to roll out at other places, but because the lack of funding, because the lack of funds, we are in a fix how to start it. And then to come up with action plans, how to go about. A new PC1 is almost ready. And in 2017, we had rolled out 3 strategies. One is going through primary and secondary, meaning by these are 3 special areas which are exclusively in Punjab, but then in the other provinces as well, they have roughly the same thing. But primary and secondary has responsibility through the clinics at Tehsil headquarters, district headquarters hospitals, special healthcare at the tertiary care hospitals, and then an exclusive institute, Punjab Pakistan Kidney and Liver Institute, which has an extra mandate to provide research and liver transplantation as well. So what are the strategies? We need to effectively identify the patient who's suffering with HCV at the point of contact. We need to do the mass screening. We need to do the contact tracing for any patient who is found positive in the hepatitis C. These 3 have been done quite effectively. But public health education awareness, number of media campaigns have been made. They have been run successfully, but the impact needs to be studied. And right now we're trying to get it included in the school education program as well. Micro-elimination drives need to be upscaled. We have tried doing it in various universities, various schools, various institutions, but the community level is the one which we did in our district near Lahore, which is called Nankana. And then advocacy role modeling through the public figures, through the political figures, through other media person has been done, although I shall say that the gap still exists. In partnership with family physician sister organizations is being on the card, and at certain places we have achieved the success and other places we need to go forward. Let me give you a few highlights on Punjab. Punjab Hepatitis Act covers these things quite comprehensively, and I urge and I think that other provinces should need to, or other provinces need to adopt this Hepatitis Act quickly so that they may also be on the same page. Robust surveillance, auto-destructible syringes, registration of the barbers and beauticians, one of the people who can spread the disease, and safe blood transfusion. These are the ones which are crucial. At the same time, compulsory hepatitis B vaccination for all neonates, compulsory vaccination to all neonates, not just hepatitis C, but B is also important, and healthcare waste management through incinerators, through proper disposal, and dialysis surgeries, organ transplant organization, registration, and finally testing of inmates, prisoners, hostels, people with challenged medical conditions. They all need to be done effectively. So for that, there have been 147 hepatitis clinics at tertiary, district headquarters, the seal headquarters, where we are able to provide the preventive and curative services. And this is only and only possible if we have got adequate diagnostic services. And for diagnostic services, let me tell you that in the past a month or so, we have been able to test 60,000 samples of hepatitis C PCR. But otherwise, although these labs are being used mostly for COVID purposes at the moment, but then we have a facility of 13 labs in Punjab who can do the testing. The bottleneck is possibly the supply of the relevant kits, although with proper planning, it can be brought to use. 147 vaccination centers are there, and then everything is being monitored through the through our dashboard program. If you can see that this is when the COVID had just ended, and you can see the figures which are there on the screen, and just the registration all the way to PCR sample recommended, sample received, and their reporting and enrollment to the treatment. And currently we have these figures. Each and every patient who gets reported, just as Professor Wahid has shown in his chart. On this cartoon, you can see that each and everything is mentioned. Each and every patient is registered. His treatment is monitored until and unless his SVR is achieved. The patient is not rolled out of this program. Now, in the last few minutes, I'm going to highlight the impact of COVID-19 on hepatitis-related activities. And I fully endorse this message that we should not let COVID-19 undermine the hepatitis elimination efforts in our country. We have suffered a lot. If you look at the hepatitis control program of Punjab, you can see that starting from 9,954 patients in January, in May, June, and July, we had the peak. The numbers got down significantly, so it did affect. In one of the tertiary care hospitals, which was quite busy in managing hepatitis C patients, from 3,381 patients, it got down to 349, 347, 356 during this peak time. Although the number has again come back. In another major hospital of Lahore, a 2,200 bedded hospital, where again we have a big hepatitis center. Although the numbers in last week 180, and then in January 155, but the numbers go down to 858. So a major dent on the hepatitis related activities in these patients in the centers. So same as the case with the National Medical University Hospital, again a major hospital of the province, Westabad Medical University. Again, you can see the numbers go down from 325 to just 84, 46, 32. So a major dent in all these places. Same as the case with Rawalpindi. One can see the trend that the whole thing has affected very heavily, and this no HEP appeal has got affected severely because of the COVID. So we need to again scale up the effort. Alhamdulillah, up till now, the Punjab Health Department has taken the challenge. The pending PCRs have been done, and again we are on track to treat the patients effectively and efficiently. The numbers in the hepatitis clinics in the tertiary care hospitals are also going up, and we need to have a target of achieving end hepatitis by 2030, and this only and only possible if we work hard, work efficiently, and work together to achieve this goal. I thank you for your patient listening.
Thank you. Thank you very much, Professor Ghias, for giving us a great overview of the situation in Pakistan. And it just will open up, when we open up the discussion, we're going to take this further. Our last speaker for today is none other than Dr. Sanjeev Arora. He is the founder and director of Project ECHO. ECHO stands for Extension for Community Healthcare Outcomes. It was developed to improve both capacity and access to specialty care for rural and underserved populations through service delivery, education, and evaluation. Dr. Arora is also a distinguished and Regents Professor of Medicine with tenure in the Department of Internal Medicine at the University of New Mexico Health Sciences Center. He's a great friend who's very passionate about seeing echo grow globally, particularly in Pakistan. And he's going to talk about success of echo model in HCV elimination. Over to you, Professor Arora.
Thank you very much, Asad. Thank you. And I really enjoyed the presentations by Dr. Wahid Das and Dr. Tayyab, and congratulations to both of you on this amazing work that you've done and leading the world on elimination. Yeah, so, I started Project ECHO in 2003. I'm a hepatologist like all of you, because I was troubled that in New Mexico, which is a state in the Southwest United States, there were 28,000 patients with hepatitis C, and less than 1,500 had been treated. And I was running the only dedicated hepatitis C clinic in the state in Albuquerque. And there was an 8-month wait to see me, and people were driving hundreds of miles each way to come to see me. And poor people didn't have access because they didn't have the ability to drive 200 miles each way and come to see me while they were getting interferon and ribavirin. So even though the medicines were available and diagnostic tests were all available where they lived, it was really impossible for them to get treatment. And what was really frustrating for me was they were coming in with liver cancers and liver failure and dying, and I was perturbed. How should I get better access? I was working all the time, but yet I could not treat enough patients. And so we started ECHO to tackle that problem. I'm going to share my screen at this time. Oops. Okay. And I'm really honored to be able to share our experience with you. ECHO stands for Extension for Community Health Outcomes. And our mission is to democratize the implementation of best practices for healthcare to underserved people all over the world. We have a goal to touch the lives of 1 billion people by the year 2025. So in Pakistan, we know that there are about 12.9 million who've been infected at some point, with about 8 million who are chronically infected, which is higher than a previous estimate, but sort of both of them appear to be in range. And today I want to make the point that we would like to offer ECHO to every province in Pakistan. And of course, there is no cost for it. We would offer you the technology platform and the Zoom platform so that we can move knowledge instead of moving patients and providers, so that every patient in Pakistan can get treatment, can be diagnosed. We can set up infection control echoes so that we can scale up infection control practices, echoes for community health workers to train them on raising awareness, screening patients, echoes for blood laboratories for best practices, and of course, echoes to train people on treatment of hepatitis C, but also for the purpose of managing patients with cirrhosis after treatment or before treatment. So what is the ECHO model? If it can do all these things, so I was facing this problem in New Mexico, and I set myself a goal that I wanted to get treatment to everyone in New Mexico. And so the model is consisting of 4 key ideas. One is amplification. How do we use technology to leverage scarce resources? In this case, I needed a psychiatrist, a pharmacist, and me at the university to be able to give interferon ribavirin safely. The second idea was to share best practices. And what we said here was, I went around the state of New Mexico, which has about 2.3 million people, and I set up 21 new centers of excellence for treating hepatitis C in New Mexico. 5 were in the prison system, where we had been doing screening and found that 40% of the prisoners were positive for hepatitis C. And 16 were in rural areas. And I asked these primary care clinicians, these were either doctors, primary care doctors, nurse practitioners, or physician assistants, and I asked them, I'd like you to treat hepatitis C. Here is my protocol. This was the AASLD protocol, but not a single one of them was willing to treat hepatitis C in the prison or rural area. because they said, look, this is like chemotherapy and this is dangerous. We haven't done fellowships like you. So we really can't do this. So I asked myself, how did you become an expert in hepatitis C? So when I did my fellowship in Boston and Massachusetts, I would see a patient present to my professor, see another one present to my professor, another one professor, and after 2 years, they started calling me a gastroenterologist. So I said, aha, I'm going to use this same model to create new hepatitis C-ologists in New Mexico, where none existed, so that everybody could get treatment close to their home. And then we would use a web-based database to monitor outcomes. So to call it ECHO, all 4 of these things should be present. So in 2003, I started the first ECHO project. In the big box is a liver specialist, a psychiatrist, and a pharmacist. And these 21 sites from all over New Mexico would join. And one by one, they would present patients of hepatitis C to each other. And in a 2-hour session, we would discuss about 10 patients in a de-identified way. And 15 minutes, I'd give them a lecture on hepatitis C. And we did this again and again and again, week after week. And what we found was something very interesting happened. That in about 18 months of doing it, they had become complete experts. And the wait in my clinic had fallen from 8 months to 2 weeks, and tens of thousands of patients got treated in their rural communities. So what we had found was that as we were doing research, and we published this first in hepatology, that these doctors were having tremendous increases in self-efficacy. Their isolation, professional isolation was going down. It was actually producing joy of work for them by building communities of practice. And in addition to professional satisfaction, professional isolation, and joy of work, and self-efficacy, their knowledge went up. And I was finding that their cure rates were quite high, very similar to what I was seeing in the university. This is still data with interferon ribavirin. So we have, in partnership with the federal government of the United States, we got a federal grant, and we did a head-to-head study in which we compared the outcomes of interferon and ribavirin treatment, pegylated interferon ribavirin, in rural areas and prisons by nurse practitioners and family doctors versus the university. We did a head-to-head study and published this in the New England Journal of Medicine in 2011. And these are the results in the NEJM. Minorities were 68% in ECHO, 49% university. Genotype 1 cure rate was 50, 46, 70, 71. So it really identical. And we were able to prove that using the ECHO model, a nurse in a prison could produce the same level of outcomes as university specialist teams could. This was a very big game changer for us, because now we said we could use it all over the world for a lot of different, less complicated things. So we said, in order to do major changes in the world, we needed something called force multiplication. And the reason we came up with the idea of force multiplication, which we defined as an exponential improvement in capacity to deliver best practice care. We needed 10 times capacity expansion. And I would argue with you, for hepatitis C elimination in Pakistan, you need 10 times capacity expansion, not just for treaters, but in raising awareness, in screening, in counseling patients, in putting infection control practices in every practice in Pakistan, in making your blood supply completely safe. All of this requires huge. So what is the extent of the specialty shortage in the world? Let me give you some statistics here. We believe that in the world today, 6 billion people don't have access to the right knowledge at the right place at the right time. And it is impossible to get the right knowledge at the right place at the right time. If you don't have the right knowledge, you cannot get the right care. So let me give you an example of what is happening. In the world today, 1.6 million people die of tuberculosis every single year. In India alone, 1,100 individuals die of TB every single day. Even though they have gene expert machines everywhere, like you have in Pakistan, the treatment is completely free for TB, but we cannot get the right knowledge at the right place in that country as in many other countries. Similarly, 1,800 children die of diarrhea every single day. We know as gastroenterologists and liver specialists that with oral rehydration and some simple antibiotics, these children's lives can be saved. But once again, the right knowledge doesn't exist at the right place. So we thought, why don't we make a nurse as good as a specialist for the most common healthcare problems in the world, like chronic pain, substance use, mental health disorders. And I encourage you all to use ECHO. Our licenses to you will be unlimited. You can use it for 100 diseases. You can use it for chronic diseases like hypertension and diabetes and mental health disorders, as we are using in many countries. And then if you cut horizontally and make a nurse as good as a specialist with the weekly ECHO clinics, you will get 10 times capacity expansion. So the next step in ECHO was, now we could use it for a lot of different conditions: antimicrobial stewardship, autism, behavioral health, osteoporosis, cancer, cardiology, chronic lung disease, crisis intervention for children, for trauma, diabetes. We then expanded ECHO into the field of education, where we found the same problem was occurring in the US, where just like rural patients were not getting the right care, rural students were not getting a good education because their school teachers didn't have the right knowledge at the right place at the right time. So now ECHO for education is one of the fastest growing ECHOs in the world, where the mentees are not doctors and nurses, but teachers. So of course, hepatitis, HIV, high risk pregnancy. This is another area where I'm very interested in bringing ECHO to Pakistan. Opioid use disorder, prison peer education, quality improvement. So quality improvement ECHOs are present currently all over the world and can be used very effectively for making the blood supply safe, for building infection control practices in remote clinics in Pakistan, in hospitals. And tuberculosis, of course, shouldn't be forgotten yet. So why do we need something like ECHO? If you see here, medical knowledge is increasing exponentially. This paper shows that in starting 2010, it was doubling every 3.5 years. It's very difficult for a rural doctor to keep up. Their learning capacity is not going up, and therefore, but the mind does not know, the eye cannot see, and therefore a lot of suffering occurs because of this changes in growth pattern. We put ECHO in the Veterans Administration Health System of the United States. These are 9 academic VA hubs. The veterans have 150 hospitals in the US, 600 clinics got connected, and they do ECHO for 39 disease areas. This is ECHO with the US Department of Defense, with hubs in Belgium, Germany, Italy, Japan, South Korea, and many states. In order to get to 1 billion people, we said any university in the world or any not-for-profit NGO that wanted to learn how to do ECHO, we would give them our technology for free. So I acquired the worldwide Zoom license that I can give thousands of Zoom licenses, and I want to give thousands to Pakistan so that you can connect your health system. But at this time, every major university in the United States, University of Washington was the first to launch, then University of Chicago, then Harvard, then Johns Hopkins, and MD Anderson. Currently, we have 240, University of Michigan. We have 241 hubs in the United States connected to about 60,000 sites in the US. 70% of the land area in the US has ECHO providers being trained. But of course, only 300 million people live in the US. So the question was, how do we get it to the rest of the world? So we started training countries, we started training universities all over the world. And you can see we have hubs in Australia, Myanmar, Vietnam, Thailand, Kyrgyzstan, Kazakhstan, Georgia, lots in India, Pakistan. I want to thank Asad Chowdhury for his tremendous leadership in bringing ECHO to Pakistan. And he has been truly, in all honesty, not because he's invited me, I am totally inspired by this man. Not because he's very knowledgeable in gastroenterology, but his desire to serve the people of Pakistan. Of course, he's very knowledgeable in GI and liver disease too, but somebody who starts an NGO to help all the people in Pakistan is extraordinarily interesting to me. And then we have lots of hubs in Africa and of course in the United States, Latin America, etc. How about hepatitis C? We have 51 hubs in the world. All over the world, echo is being used for the purpose of achieving, of course, trying to achieve hepatitis C elimination. Georgia is a country which used echo extensively, and uniformly people are getting extraordinary results. Of course, I must say that we have I know no one in the world who has achieved the results that Wahid Das and his country have achieved in Pakistan. And so for that reason, I totally admire them. This is in Argentina, again, showing that they were able to get a 96.4% cure rate using echo in the rural provinces of Argentina. This is the Veterans Administration health system in the US showing that if their doctors participated in echo, the likelihood of getting treatment was 8 times, 21.4% versus 2.5% amongst non-participants. This is VA echo again published for cirrhosis in hepatology in 2018. If the doctor participates in echo for cirrhosis, the risk of death was half than if the doctor does not participate in echo, because this is for patients with advanced cirrhosis of the liver, echo. This is Punjab, India, treated 88,000 patients. They published results for about half this number in the European Journal of Hepatology, 91.6%, again, mimicking the results that Wahid Das talked about. These are the results of Dr. Asad. In all these different rural clinics in the centers, he put echo there, and you can see on the right, the SVR12 results are way over 90% in all these 14 centers that he has listed here. This is, he also has started this ambassador youth movement using the echo model to train students on raising awareness for echo. Now, we have 275 peer-reviewed publications on echo, and currently showing that doctors like to participate. They are satisfied. There's declarative knowledge, procedural knowledge increases 81, competence 67 publications, 33 showing patient health outcomes, and 2 showing community health outcomes. This is our work in Africa and Namibia for HIV care, treating 200,000 HIV patients in the district hospitals. Namibia, this is the Windhoek, the expert team. In India, they used it for the COVID-19 response, as you have used echo, and have trained 296,000 healthcare workers. Overall growth of echo in 2019, we had 236 mentees participating, and in 2020, so far in the first 8 months, we've had 622,000 learners in 158 countries participating in echo projects. So really, what makes echo work? These are the last couple of slides. Team-based care. Task shifting is the idea of every human being working at the highest level of his human potential. We think this requires interprofessional consultation, many experts helping you, guided practice, mentor-mentee relationships, very much like you got during your residencies and fellowships. Echo is also a social network. It produces joy of work. We have 80 publications showing that. It produces joy of work for rural clinicians. Technology reduces the cost of collaboration. Force multiplication is 10 times. My pitch is that if Pakistan is ideal for echo because you have so many world-class experts in the cities like Islamabad, Karachi, Lahore. If we democratize their expertise and take it to every rural part of Pakistan, we can change the game for hepatitis C and many other diseases. The key principle in echo is all teach, all learn. It is not just that the rural doctors will learn from the experts. You will learn from them. They will learn from each other. When the ECHO model works, it works because of love and respect and kindness and empathy. And we learn about the social, cultural circumstances in which patients live. And we learn about the barriers to implementation. ECHO is a movement to change the world. And I invite you all to join us. And how does ECHO really work? This is a movie. I know many of you have identified which one this is. This is Godfather 1, and that's Marlon Brando. And Francis Ford Coppola is leaning over him. Marlon Brando is asking Francis Ford Coppola, how do you make a great movie? And Francis Ford Coppola says, get everyone to make the same movie. This is what we need if we want to eliminate hepatitis C in Pakistan. And how would we do that? How would ECHO help? ECHO can facilitate. Of course, it is you who will be doing it. How do we facilitate it? There are 5 things required for collective impact. First, common agenda, shared measurements, reinforcing activities, continuous communications, and ECHO could be the backbone of these operations. Vahid Dash showed a classic example where he put all 5 of these principles, 5 of these principles in place and achieved such amazing results. And ECHO can facilitate these conditions to bring quality improvement, infection control practices, educating community health workers, nurses for screening, doctors for treatment, diagnosing patients accurately, linkage to care, vaccinating, treating patients with cirrhosis, treating with hepatitis C, and setting up ECHOs for the purpose of quality improvement. ECHO is very aligned with 4 UN development goals: good health and well-being, quality education, gender equality, and reducing inequalities. And I will stop here. Thank you for your kind attention. And I'm so honored to have a chance to meet with you. So honored to hear my co-speakers. Thank you.
Thank you very much for your very kind words and your passion. Okay, so I'll just go through questions, some that I have in front of me, and then we'll take the opinion of experts. The question to Dr. Wahid Doss is, how did Egypt achieve and enforce safe injection practice, and how did the government change public perception on the subject of unnecessary injection? Dr. Doss? You are muted, sir. Let me...
No, I'm sorry.
Yes, please go on.
Yeah. We have recently introduced the widespread use of auto-destructive syringes, which are single-use, of course, can't be reused. And in this way, we hope to decrease any transmission of blood-borne infection like virus C or virus B through injections. And we try to enforce that people take less injection than possible. As you mentioned in Pakistan, in Egypt also, the patients love to take injections. We try to sort of change this mentality and try to make people take oral medications when possible instead of injections. But the main achievement is through the introduction in Egypt of auto-destructible syringes. Very important.
Thank you.
We don't have a process of harm reduction in Egypt so far. We'll establish that soon. One more thing is that we have been able to supervise or to prevent HCV transmission in barbers, which is a very common source of infection in Egypt, through legislation which came out about a year ago. And barbers are scrutinized and supervised, and in this way we will hope to eliminate the infection through barbers.
Thank you. I will now move on to Professor Gyasun Nabi Tayyib. Similar question. How can we alter public behavior on safe injection practices here, Dr. Gyas?
I think 3 things. First of all, legislature, which is already there. Its proper implementation is very important. Dr. Wahid has very rightly said that auto-destructible syringes, We are already onto that, auto-destructible syringes and then beautician and these beauty salons. They all have been registered all across the province, and similarly the activities or efforts are being done in the rest of the country as well. And then finally, unless we change the behavior and attitude of the people, we'll not be able to successful. We have to start from the kids. And in the children's books, we need to include them as a part of syllabus on the health education, communicable diseases and non-communicable diseases, how to stay fit. And up till now, we have been able to successful to get it included into the syllabus of the younger children on the injection safety and hepatitis control for the kids. And then obviously mass bombardment on the in the communities about the injection safety, injection avoidance, and blood safety. All these risk factors we bring on hepatitis C, HIV, and hepatitis B.
Thank you. Here now I would like to request Professor Graham Foster is with us, and he had a very enlightening talk on hepatitis C elimination last night, very late last night for us, but it was a great talk. We'd like to hear from you, Professor Foster.
Asad, colleagues, dear friends, thank you very much for asking me to come along and join this session. I think the thing that emerges from the talks that we've heard is a sense of real optimism, isn't it? I think we heard from Wahid that this is very, very doable. And I have to say, Wahid, I think the WHO has really let Egypt down. They were very keen to tell you what the targets were, but they've been very poor about rewarding you when you've hit them. And I think the WHO really should agree that Egypt has eliminated hepatitis C, and I think you should get appropriate recognition for that. So I think that's a mistake from the WHO not to reward you for your efforts. I think that's important. But I think you've shown very clearly what can be done. It's extraordinary what's already happening in the Punjab, and I congratulate you on the programs there. I know Huma Qureshi is on the panel doing very similar things in Karachi and in Sindh. So I think there are already fantastic programs underway. And Sanjeev, I continue to applaud your efforts to bring healthcare professionals together, because that's really the secret of success, isn't it? Get all the right people in the right room by the magic of Zoom, and then magic happens. So I think Pakistan has got a really good chance of eliminating hepatitis C. And I think that our job really is to keep encouraging our people, encouraging the politicians to support this. I do not see a barrier to eliminating hepatitis C in Pakistan. There are some technical challenges. I think the slight complexity of genotype 3 needs a little more work, but there are projects underway to start examining that. There will be a little bit of subtlety about reinfection. There'll be some challenges way along patients who fail treatment and don't respond. So yes, there are some challenges ahead, but I think this is very doable. And I congratulate the team that we have assembled here today. And I hope that what this last hour and a half has done is to encourage people to go forward and get going, because it just seems to be something we can do, doesn't it? And there aren't many times we can get together and say we really can do this, but we surely can.
Thank you. I'll now go over to Professor Dr. Huma Qureshi. She has loads of experience under her belt about hepatitis elimination. Dr. Huma, would like to hear from you.
Okay, thank you. Can you hear me, Asad?
Yeah, I can hear you.
Yeah, thank you. Thank you, everybody. And I would really like to congratulate Dr. Wahid, Sanjeev, and Qiyas for giving us a very good information about what's happening globally on disease elimination. Like Egypt was the first country to have the highest prevalence of HCV in the world a couple of years back. And with a lot of commitment from the government and from the healthcare experts, they were able to eliminate the disease, and they're the first country in the world to eliminate the disease. And I heard a couple of weeks back that WHO was doing a validation study for them for the elimination of hepatitis C. And because this is the first country in the world to eliminate hepatitis, so they were not sure about what tools to use. So they were really working on the tools, because so that's a great achievement for Egypt. And hopefully, like Pakistan stands as the second country. In fact, now it's the first country in the world to have the highest disease burden. So we are also making plans where the Prime Minister is launching this HCV elimination program for the whole country, and where they're going to support the provincial hepatitis programs by providing them with the screening and the testing and the treatments through the Prime Minister's program. We are targeting at about almost 120 million population who are eligible for treatment. And the PC1 or the project is for 10 years. And in the first 5 years, we'll test and treat 50% of the population, which is about 60 million plus population. And in the second session or in the second year, the first is from 2020 to 2025, and then from 2025 to 2030. We are going to look at the gaps where we were not able to achieve the targets, and also add on the next 50% patients who are awaiting treatment. And in the second stance, we're going to also treat the children, because in the first go, we are not going to treat the children, because right now we do not have the oral syrups or the medications for children. So the local pharmaceutical industries have been asked to produce the pediatric doses, but right now, because we only have adult doses, so we cannot treat children less than 12 years of age. So these would be treated in 2025 to 2030. And as you all, and the cost of this program is about $352 million. And we are also working on the availability of the auto-disable syringes, because like Wahid told us, that because that's the only way that you can stop people from taking or reusing a syringe, because people have this desire to take injections, and the physicians or the healthcare people have the desire to use one syringe for multiple uses. So the only way to do is to remove the multiple use syringe via auto-disable. And then obviously the infection control and the safe blood, which is also being tackled. But the use of auto-disable syringe and its procurement and local production is on the high on the agenda. And then we have also added the use of eco for the transfer of technology and for the awareness in the project. And we have put this very clearly, that for the far-flung areas where it's difficult to access, and where the health professionals are few, and we need to send the treatments and the testing, cascade, we would use eco to train these people. And I'm sure that, like Asad told us, that we have been using eco in Punjab quite a bit. Some parts even in Sindh are using it, but it needs to go much more, because this is not like Pakistan. We should be having it at every clinic in the government sector, in the district headquarter hospitals, and even in the rural health centers and the primary care centers, because we have a dearth of people who are well trained. So this could be used as a very good training tool for our population. And like it's possible to treat, it's possible to screen and treat and cure and eliminate hepatitis from Pakistan, because we all know that we are producing the very effective generic drugs within Pakistan, which are the cheapest in the world. And they're still very effective, although pharmacokinetic studies are not available, but the quality assurance is not available. But still, we see the cure rates, which are over 98% with SOF and DAC. So that's quite comparable to the global, cure rates. So I think with such a efficient, effective, and low price medicine available to us, all we have to do is screen huge populations and then test them and then treat them. And as Riaz said, that we need to link all these, because if you test many and then don't put them to treatments, then you're going to lose the population, and that would be a disaster. So we are also using a network of softwares where we are going to use these people to track and see, so that we don't lose them. So this program is a novel program where all the deficiencies which we have had in the past programs have been addressed, and hopefully once it is launched, it would bring fruit to us, and we would be able to eliminate the disease from Pakistan very soon. And the last thing is that I would like to let you all know that Homi from CDA, the Center for Disease Analysis, is working with us on the modeling of the hepatitis C elimination from Pakistan. And so like Fasiha, and who showed that it is possible. Peter Wickerman from Imperial College is also working with us. So we have the people who are supporting us, but now all we have to do is a good commitment from our government, which is there, and a good commitment from our healthcare people, experts and practitioners, to really test and treat people and eliminate the disease, which is possible like we see in Egypt. Thank you very much.
Thank you very much, and I hope we are able to pull it through, Dr. Huma, and we stand by, the ECHO will stand by you for all efforts in Pakistan, inshallah.
Thank you.
Dr. Arora, there's this question for you. I mean, it's been partly answered, but we just like to know your view. How do you see ECHO integrated into, how do you see ECHO integrating into Pakistan hepatitis C elimination program and make it more effective? So we'd like to know from your experience, India, Georgia, there have been big programs with ECHO.
Thank you. So I think usually in most countries where, so about 10 countries have signed collaborative agreements with us at a national level. As you mentioned, India is one of them. And once that country signs the national, or there are others like Kenya and Namibia and others, Africa, etc. What happens is we give them the platform and we set them up with a training site, which we call super hubs, so that within their own country, they have the ability to train people on adopting the ECHO model and have ability to give out the Zoom licenses and the other software that we provide to track, so that we make them independent of the US Institute. That's the first step. So that you should have your own ECHO, your own super hub, your own training system. Second, what they've done in India and in many countries is they wrote ECHO into the National TB Guide. So the entire national TB program in India, which, as you know, is one of the largest TB programs in the world, operates on ECHO with every hospital district connected. Similarly, the guidelines for the hepatitis C national program, the mental health program, and they have another program called Ayushman Bharat, which is what I think Huma was talking about, the equivalent of that, meaning that they have these health centers in these small areas and small towns, and they have primary care clinicians there, but they don't have all the knowledge. So setting up ECHO as a general support system for amplifying administrative practices and management of chronic diseases and rolling out national programs. But really, essentially what happens is, and now for COVID-19, for example, so for to give you an example of COVID-19, what's going to happen, for example, in Pakistan very soon, is that a vaccine will be available. So let's say 6 months, 8 months from now. Now, in order to get a vaccine to all the people of Pakistan, you need rapidly done. It can't be done over 10 years. You want to do it quickly. So you have to firstly overcome vaccine hesitancy. So you need to train a very large number of people on educating individuals on why they should take the vaccine, what's the benefit for them, how will they benefit, how will their families benefit. Then you have to train vaccinators, because a lot of countries don't have such a large adult vaccination workforce. In many countries, it's just children and pregnant women getting vaccines. So you need a much larger workforce. They have to be trained. Then when you are vaccinating at that level, you're going to have a lot of people who is going to have side effects. You need someone who can manage those side effects. Some will have very serious side effects. They'll go to your district hospital. So the point I'm saying is that ideally, if you want integration with the health system, it typically doesn't start with one program like hepatitis C and goes up. It starts from the other way, that the government adopts the model for training and development of its workforce, and then uses it for whatever is their topmost priority at that time. So in the Africa, it's mostly HIV, TB. In Europe, it's different. In India, it's different. So essentially, that's how it typically works. And we certainly are happy to, as we know that your government, the National Institute of Health in Islamabad, uses ECHO for antimicrobial stewardship. But it's just one program. I think we should consider it at a broad level, using the technology for workforce training and development. Asad.
Thank you. I'd like to have a quick comment from Professor Ghyas on this, what Professor Sanjeev has said, and then I'll go to Professor Hashmi. Yes, Dr. Ghyas?
Thank you, Asad. I think Sanjeev has very rightly pointed out on the utility of ECHO, and Dr. Huma has very nicely elaborated on the national program. I believe that the solutions have to come indigenous according to our own requirements. We have a very robust healthcare system down to the grassroots. We have the rural health center, we have got basic health units, we have penetration all the way to the smallest possible place through LHVs and all that. We just have to use that system effectively and efficiently. At the same time, our family physician system is again variable, and we need to bring it to our loops, either through the ECHO or through some other mechanism. And then incentivization is again very important for family physicians. If we use these two combinations effectively, I'm very hopeful that the result that Professor Vaid has shown in their program, maybe down the road 3 to 5 years later, we, Dr. Huma or me or somebody else as our successor, may be talking of exactly the same thing as Dr. Vaid has said.
Thank you. Yes, Dr. Hashmi, we'd like to hear from you. You have been involved in hepatitis elimination efforts since very long time.
Thank you, Dr. Asad. Thank you very much for having me in the panel. Obviously, I'm not in a position to contribute the way the rest of the speakers and panelists they have contributed. But I have a couple of remarks to make. I believe that in a country like Pakistan, public-private partnership is the only way forward. And I congratulate Professor Ghyas that finally, under his leadership, there has been at least one MOU signed between the Punjab government and your trust. And I'm sure there are several other trusts working in the province. And if we all join hands, because the goal is the same, and if we join hands, it is like joining all our resources, etc., for the common goal. And I'm sure with that we can achieve our goal of elimination. But just I don't want to take the hope or optimism away, but just a very a different kind of a remark, that what we have observed is a kind of reluctance on part of the patients, even when you offer them free diagnostic facilities, free treatment, and even when you take the point of care to their residents, close to their residents. We have been practicing this for the last decade and a half. And my own perception is that there is something like 20% of patients who are genuinely willing to be treated, and they are not having the treatment because of some limitations. So if you offer them free treatment, and if you take the point of care to their residents, they are the one who would accept all those. But a significant percentage of patients, for reasons which I believe I thought that so wonderful people in this meeting probably would touch upon this. Why, after all, a significant percentage of patients is reluctant not to be, linked to the care for one reason or the other? Could it be that health is not a priority as long as the disease is asymptomatic, or economic reasons, or some other reason? And I think this is where we all are required to work really hard if we intend to achieve the goals which the WHO has set. I would like to remind that long before WHO set these goals for the rest of the world, our country started, and Dr. Huma would second me, that our country started a Prime Minister hepatitis prevention or treatment program long time back. It didn't work, didn't have the same kind of results that we all hoped. So could we just request our colleague from Egypt to get us the political, kind of a will, get us some of the political will from Egypt, or some sort of measures have to be taken. Something is wrong somewhere, because I believe that still majority of the patients, despite the fact that we offer them free diagnosis, diagnostic facilities, free treatment, and we offer all these at their doorstep, still we are in no position to achieve the results. Thank you for having my opinion. I apologize for this rather a kind of, it is no criticism, but this is my observation during the last 2 decades or so that I am involved.
Thank you, sir. A quick comment from Professor Yasun Nabi Tayyab, and then I'll go to Dr. Sadiq Mehman, who's also the chairperson of this session.
No, Dr. Asad, I don't have any comment to make. Do I have anything particular to talk about? Because maybe I missed something.
Okay, it's okay. Dr. Sadiq Mehman is here from Hyderabad. Dr. Sadiq, are you with us?
Assalamu alaikum wa rahmatullahi wa barakatuh. Yes, I am with you.
We can hear you. Yeah. So we just like to have your comment as the chairperson. So we are winding up the session now.
Regarding the elimination of hepatitis C, for the thing is that we all are working for elimination of hepatitis C, and to me the best model is the Egypt model for us to follow. And the other thing is that we have many attempts to get out of Hep C from Pakistan, but unfortunately it is not successful, whatever the reason. But I think it's better to have a public and private partnership and to get rid of this hepatitis C from Pakistan. We also know what are the problem in our part of the world, and we also have to address every problem at every time. Political will, politicians should be involved. The scholars, religious scholars must be with us. Almost so many religious scholars, they have their own channels. So we have to have with them some programs regarding the how to eliminate hepatitis C. And the political parties, they have their channels as well. So we have to, join with them in various parts and convince the people everywhere. The other thing is the corona. In corona, we have a lockdown concept. So if we make a lockdown, say for example, in Gojranwala, Hyderabad, we have a 7 days lockdown in each, small division, is in a small district of the Hyderabad. Like in Hyderabad, we have 4 districts. So every district have a 1 or 2 days lockdown, and that time we have to check everybody. What other thing is that we should, release an NIC in which we have to write down the HCV elimination has been checked. And whenever the people are coming for the job or they have family resistance certificate, the family resistance certificate should have one column of FC or FB has been checked and the family has been vaccinated or not. Without this, nobody get the job, nobody get the any transfer from the country for any journey or anything. So if you hoga ye कि if the people are away from this program, they have to have a penalty for this. Until unless you will not put the penalty to the pupil, they will not come and get checked their hepatitis B and C. Even they are in the home, they will refuse that the pupil are not their home. Bhai ghar pe nahi hai, abba ghar pe nahi hai, you will see like this. So until unless you have to have obligation, primary obligation for certificates, for getting job, you should have a HEP B and C elimination certificate, or you should have a column in all the certificates where you should get the job or NIC or passport, FC and B elimination form. Thank you very much.
Thank you. Thank you. We are now moving towards the end of this session. I'll request Professor Abdul Qadir Khan for his comments, and then I'll wind up the session.
Very much, Dr. Asad Chaudhary, for inviting me and taking my opinion. And Sadiq Memon was rightly saying we can add the political leadership or leadership of the people. Then we can add the we can do the early diagnosis and the screening strategies. Then we can go to the diagnosis and treatment of hepatitis C, and we have to invest about 10% of the yearly health expenditure for going to the elimination of the hepatitis C by 2030. And we know the Egypt has done this rightly, and Dr. White Dose was rightly saying about the elimination of the hepatitis C from the Egypt. So there are problems in our part of the world, the population and the education and the many things that people are not understanding. And like we are working in SIN, where the reuse of the disposable syringes is the most common mode of the transmission of the hepatitis C, and the people are not taking the oral medication. They are insisting for the injections and they are asking for the treatment. They are not satisfied with the oral medications. So by doing this, avoiding the reuse of the disposable syringes, by increasing our healthcare budget on the diagnosis and the management and the prevention of the hepatitis C, then we will be able to achieve the target of the elimination of the hepatitis C by 2030. So thank you very much, Pakistan Society of Hepatology, for including me in the chair of the experts. And thank you, Dr. Asad Chaudhary, Dr. Zishan, and the Dr. Javed Iqbal. Thank you.
Thank you. Thank you very much. It has been a wonderful session, and I conclude by saying that to achieve elimination, we have actually to take treatment to the people, and ECHO is going to have a pivotal role in this. We learned a lot. Thank you very much, Professor Doss, Professor Yasuna Bitaya, Professor Sanjeev Arora. It has been wonderful, and my all chairperson, Dr. Huma Qureshi, Zaid Hashmi, Sadiq Mehman, and Professor Abdul Qadir Khan. And we really miss you on behalf of Pakistan Society of Hepatology. I think an in-person meeting is due, so you are not excused. So till next year, I'm seeing Professor Foster here as well. So we are going to invite you, and we're going to sit together over a cup of coffee and carry on discussion for a long, long time. Thank you so much. So I'm going to call off this session. Bye-bye, everybody.
Yes.
क्या फॉर्म देना